We're moving right ahead now to talk about feeding and eating disorders. So, feeding and eating disorders are serious, potentially life threatening conditions that are characterized by somehow abnormal eating patterns. In this section of the DSM, anorexia nervosa, bulimia nervosa, and binge eating disorders are included, as well as feeding disorders such as pica will also be addressed. So first we're going to talk about eating disorders, and then we're going to move on to feeding disorders. So people who have bulimia and anorexia have maladaptive beliefs surrounding weight, body shape, and appearance. And although these disordered eating patterns can really vary, both anorexia and bulimia share an over-evaluation of shape and weight, which leads people with these disorders to really base their sense of self-worth largely on their shape and or their weight and their perceived ability to control. So control is going to be a big issue with these in particular. So some clinical tips. So these are disorders that are frequently co-occurring with other disorders. And that shows up a lot, especially when there are controlling family dynamics. So you saw in the clinical interview that the young lady with anorexia nervosa had a mother who, insisted that she take care of her brother while she was off at work. Oftentimes, eating disorders are a way of taking back control and taking back some power in the relationship. And ultimately, the disorder, the illness itself can start to run things in the family. Not very similar to the way that addiction could run what happens. Another thing, trauma. Often trauma is kind of part of the root of an eating disorder. People will often, again, try to take control over their body after they've been in a position in which they have not had control over it. And this is adapting their eating either by restricting or by taking it in. By binging is one way that then that can show up. So it's important to recognize that medications do not fully treat eating disorders. However, they can actually be helpful. In general, when presenting for treatment, a lot of individuals with eating disorders really want to figure out the root of their illness. Unlike other cases where we do try to stabilize people and then focus on the core issue, it's really important to keep in mind that the precise etiology of eating disorders is not completely understood. There's obviously a lot of evidence suggesting that eating disorder can be attributed to the intersection between genetics and an environment. So that nature and that nurture is really important here. Because this impacts eating, how people eat, what they're eating, how much they take in, eating disorders can really negatively influence brain functioning, metabolic metabolism, and their neurochemistry. These also obviously have cognitive functioning. So in addition to the sort of behaviors that you see, there are some cognitive impacts, cognitive impairments that come along with these disorders. And how that plays out is that there can be difficulty with things like decision-making, emotional stability, and just in general, limiting the life activities of people who are suffering from these symptoms. Because eating disorders are, particularly anorexia, potentially life-threatening, it's really important to make sure that if you're working with people with this disorder, you have some specialized training around it, and that you also are coordinating and providing wraparound care. There are often a lot of medical complications that come along with these disorders. And so you just want to make sure that you're not doing it alone. So some things just generally to think about with regard to eating disorders. So eating disorders are found across cultures, although they tend to be more common in industrialized, higher income countries like Europe, the US, Japan, Australia, and New Zealand. And really with respect to cultural considerations, eating disorders are comparatively more predominant in Caucasian females than maybe in African Americans, Asians, or Latinos living in the United States. However, there's some reason to suspect that eating disorders in diverse communities are on the rise, but these individuals may be reluctant to help seek treatment. In fact, these populations are obviously less likely to seek mental health services in general, which may result in our perceived lower rate of occurrence. In terms of gender, obviously tends to be much more prevalent among females, particularly for anorexia and bulimia. However, binge eating disorder, still more women have it. There is a higher percentage and proportion of men with binge eating disorder. So just know that. And keep culture in mind when thinking about this, because certainly there are cultural differences in terms of how weight concerns are presented. Some cultures may not experience an intense fear of gaining weight the way that other people do. Like I just mentioned, of the eating disorders, anorexia really presents the most substantial medical risk. And that's really related to the fact that people have very low body weights and they're not eating enough really to survive or fuel their organs. Obviously, in many disorders that we talk about, suicide is a risk. However, death by suicide is obviously a byproduct often of a mental disorder. Anorexia is really the only mental disorder probably that can kill you. So just keep that in mind. And just as a word of caution to make sure that you're always working with other people. In general, I think it's helpful to recognize that people who maybe come for treatment with eating disorders really want to work through the kind of root of the illness. And that's certainly what I obviously have been encouraging this semester. Focusing too much on the root of the illness is really fairly dangerous because you really want to make sure that you're resolving the disordered eating patterns themselves that can actually potentially lead to death. So sometimes it's more helpful rather than focusing on the root, but to instead look at what is actually maintaining this illness, like what is happening in their world that's helping them continue to do this. Like lots of things, disordered eating is a way of coping. And before we can get people to give up their coping skills, we have to teach them new ways to cope. So just something to keep in mind here. Again, bulimia and anorexia have very similar symptom patterns, and often anorexia can be superimposed onto bulimia. Sometimes it can be a little bit confusing which disorder somebody has, and in truth, somebody may actually have both. One of the important considerations that you'll see in the DSM is the idea of the BMI, the body mass index. Normal is considered a BMI of 18.5 to 30. There are tons of BMI calculators out there, so you can figure it out or figure out what your client's BMI is. And then anything below that or above that would be indicative of, potential eating disorder, particularly on the lower end. Let's go ahead and move on to anorexia. So this is a serious and life-threatening mental disorder that is characterized by dietary restrictions that really lead to low body weight. People have a fear of gaining weight, of becoming overweight, and any sort of behavior that may lead to weight gain. Reluctance to celebrate holidays, reluctance to eat out with friends. And there's also some cognitive distortion. So the way people view themselves, the way they see themselves, doesn't necessarily match up with how they're perceived by others. And that evaluation of the self is often based on someone's weight, how big they are, how they look, whether or not they're aligning with some sort of body ideal. There are two types. The first is the restricting type. So this is when weight loss is attained primarily through diet and sometimes through exercise. So people with restricting type typically don't have binge eating or purging compensatory behaviors such as vomiting, excessive exercise, misuse of laxatives. Conversely, those with binge eating purging type do regularly engage in binge eating or compensatory purging behaviors, which may complicate the diagnostic picture. Like I said, this anorexia, is this bulimia, is this maybe a little bit of both. About 0.5 to 1% of the population suffers from anorexia, and it's thought to be about 10 times more common in women than in men. As you can see here from this video, this is how this woman is. This is how she sees herself in the mirror. Again, really focusing again on that kind of misperception, the cognitive distortion that's going on. Some more visuals about what phenomenologically that might feel like. Then for our next disorder, bulimia nervosa. So bulimia is similar to anorexia and that it is an over-evaluation of one's weight and one's body. But it's really characterized by the recurrent episodes of binge eating that are coupled with the compensatory behaviors that prevent weight gain. So a binge, when we're talking about it, is defined as eating a lot of food in a short period of time with about 2 hours that's accompanied with a feeling of a loss of control. To meet criteria for this disorder, you would need to have more than a binge episode more than one time a week for 3 months. and have these recurrent compensatory behaviors like purging to prevent weight gain. So self-induced vomiting, laxatives, diuretics, fasting, exercise. And again, the severity that you want to do that in terms of coding, mild, moderate, severe, and extreme really refer to the number of purging episodes each week. So it's really focusing more on the purging piece rather than the binging piece and bulimia. So like anorexia, bulimia can have some fairly significant impact on your body's functioning at the moment and lifelong if it goes on for long enough. Some of the things that we mentioned earlier, it can have this cognitive impact where people are not getting the nutrients that they need. It's impacting their ability to make decisions, to have memory, to plan ahead for the future. Really common things that occur would be issues with the throat and the esophagus. Tooth enamel erosion is pretty common, obviously, particularly for people who purge, who vomit. Difficulties with digestion, stomach problems, eventually it can take its toll on the heartbeat as well, too. So just know that while anorexia is the one that is extremely dangerous, bulimia is not, it's also not really great for your physiology either. Next is binge eating disorder. Like I mentioned earlier, binge eating disorder is more common in men than other eating disorders. However, obviously, predominantly a female disorder. And binge eating disorder is characterized by recurrent episodes of binge eating in the absence of compensatory behaviors. So a binge, like I said, is a period in which people eat more rapidly. They eat until they're uncomfortably full. They have large amounts of food when they're not hungry. They'll often eat alone due to the embarrassment regarding their intake. And following a binge episode might feel self-disgust, depression, or even guilt. A lot of times people will have binge episodes that they don't necessarily remember. There's some amnesia that can actually take place. And I think that's an important distinction. So while most people occasionally overeat, a binge episode really differs in a lot of ways from just regular overeating. And I would say that the biggest reason isn't just the amount of food and the rapidity with which it's consumed. The biggest thing is this perception of loss of control over one's behavior and the real secretive aspect of the binging. So again, specifiers, there's in partial remission, full remission, and then severity based on the number of, that should say binging rather than purging episodes. My apologies there. Mistaking my slide. Moving on ahead. And then I've got our other specified feeding or eating disorder, just things that are your catch-all for when people don't necessarily meet all the criteria. A common one is atypical anorexia, which is where there's significant weight loss, but the BMI is within the normal range. They wouldn't meet criteria for anorexia because they have a normal BMI. And then bulimia nervosa, where it's just less than a week or it's been going on for less than three months. And then binge eating disorder of less than a week or less than 3 months. So again, if people are doing it a couple times a month, they would fall into this category. And then the other two being purging disorder. So it's like bulimia, except there aren't the binge portions of it. And then night eating disorder for when people wake up and eat something and then forget that they eat it. And then our unspecified feeding and eating disorder, probably used most in the emergency room. So thinking about treatment planning for eating disorders, really the first idea really is important to work on prevention. So providing clients information about what it is to be healthy. There's a lot of bad information about diet and what it is to be healthy. And they're often grounded and rooted in our social images of beauty and what people need to look like. We also get our eating and food habits from our parents who may or may not have issues of their own. So oftentimes a big part of work with clients with eating disorders is really providing them with information about healthy nutrition and then really working on developing some skills such as mindfulness, yoga, body acceptance. These things are really helpful for grounding and also for reducing the amount of judgmentalness that's really going on. In terms of intervention and treatment, there are a lot out there. Most approaches really use some form of cognitive behavior therapy. Like I said, this is conceptualized as both cognitive because it's about how people think about themselves, how they perceive themselves. And it's also about some behaviors that they're doing, whether it's excessive exercise, restrictive eating, etc. And the cognitive piece would be about changing the cognitive distortions about body image, body size, healthy food intake. And the behavioral would be sort of tracking body weight, keeping an eye on what people are actually eating during the day, perhaps using some behavior activation if there is binging going on, getting people to do other things to relieve stress and to cope with what's going on in their life other than eating too much food. And then an incredibly important piece of this is obviously family therapy. Like I said at the very beginning, this is often conceptualized as a family disease. And oftentimes it emerges when there's a family culture of perfectionism and of control. And oftentimes, particularly young adolescents will respond to this by taking some control, by controlling what it is that they eat, what they have going on and going into their bodies. And this, of course, often leads to more control on the part of the parents, which leads to more compensatory behaviors in the adolescent. Family therapy can be a great way of helping families individuate so that there is a separation between people's thoughts and their feelings between members. And so particularly for over-controlling parents or adolescents who are really trying to do the developmental task of individuating, family therapy can be a great modality and an important one because, again, families can maintain this illness. And then again, if there's any trauma there, really trying to address the underlying trauma once some of the behaviors have been reduced. Obviously, it will come back if you don't address the underlying trauma. So now we're going to go ahead and move on to avoidant or restrictive food intake disorder. So this is a diagnosis that's new to the DSM-5, and it's characterized by disturbance in feeding that results in weight loss, nutritional deficiency, dependence on nutritional supplements, or alternative food intake, so your real food vitamins, or interference with social functioning. So these disturbances can show up as avoiding certain foods based on sensory characteristics like their texture, their smell, anxiety over certain foods, or really a lack of interest in eating. This disorder and the symptoms most commonly occur in children and may be associated with anxiety, obsessive compulsive disorder, or some neurodevelopmental disorders. It's not necessarily associated with there's a significant weight loss, there is nutritional feeding difficulties, and that impacts people's functioning and development, obviously, when people are small and trying to grow. And one of the things that's said on the previous slide is that people have to be fed in an alternative way because they refuse to eat certain foods. And the gastrostomy tube, the G tube, is one of the ways in which that happens. Sad photo here, obviously. Although she looks very happy. So our next disorder is pica. So pica is the disorder of people eating non-nutritive, non-food substances for at least a month without being supported by developmental, cultural, or social norms. People with pica repeatedly have compulsive cravings to ingest non-food things such as clay, dirt, rocks, paint chips, metal, paper clips, cigarettes, and based on whatever substance it is, they may have some nutritional deficiencies, injuries from what they've eaten, toxicity, and even potentially death. This one is important to consider cultural things, although in kind of Western culture, eating clay is not something. There are certainly cultures around the world for women and pregnancy to eat clay, and that's actually a culturally acceptable practice. So you just want to make sure you're checking for cultural relevance of your diagnosis. And then rumination disorder. So rumination disorder occurs when people regurgitate their food. They start to eat it, and then they chew it, and then they swallow it, and then they spit it out. It's not necessarily a GI issue, and and there's no other co-occurring eating disorders. So it's a little bit different than maybe in like purging or by bulimia. And again, rumination disorder and pica is most high among children, and individuals with co-occurring disorders, and particularly common among people with developmental disabilities. So if you have someone with this condition as an adult, oftentimes they're living in residential facilities because there are fairly considerable other mental health or neurocognitive or neurodevelopmental issues that are going on. So treatment planning, thinking about our feeding disorders here. So first of all is prevention. One of the best ways is really to try to kind of impact the environment so that people are not able to access the food item that they'd like to eat. If someone see paper clips, make sure that you don't have any paper clips in your house. If people eat cigarettes, make sure that you don't have cigarettes around the ground. Again, in terms of intervention and treatment, it's generally understood that people engage in pica or rumination because it has some sensory input. Like I said, these disorders are often common with people with developmental impairments, and eating non-food items or eating things, swallowing it, and then spitting out provides some kind of sensory soothing. And because of that, that can make treating these disorders fairly difficult. And really, the only way you can do it is to find equally motivating replacement behaviors during feeding, some other form of sensory stimulation or rumination, and then find some replacement motivators outside of feeding for pica.